So can people hear us, Emma, Kate? Okay, that's great. So shall I just make sure everybody's aware of how they do this, just so we talk them through while we come up to our start time? Anybody who's not done Kahoot before, you will need to have two devices. One, which is usually a computer to see the screen and the questions, and then you need to log on to Kahoot to actually be able to answer the questions themselves. And when you log on to Kahoot, you've got a PIN number, which I assume is the one in the bottom right-hand corner, guys, which is 170026. And you need to go onto that in order to be able to answer the questions. So hopefully everybody's managed to do that. And of course, if you can't log on, you can just virtually answer them in your heads, I suppose, if you don't want to. And of course, your name will be seen. So lots of people tend to use aliases, some of which should be clean, please.
Okay. And then have we got now the 27. I'll introduce you, Sue. Oh, sorry, I'll introduce the evening. Right, a big welcome to everybody from both BSAVA and from the Wales Veterinary Science Centre to our series of short webinars showcasing what Vets Cymru has to offer the general practitioner. We regret this year not being able to host Vets Cymru in person and very much hope that we can be back together again next year in Aberystwyth, enjoying the lovely June weather. So hold the date, that's going to be on the 18th and 19th of June 2022. A massive thank you to Eichmeyer, our sponsor, for helping us out with these 4 webinars. Do keep an eye out for the other 3 webinars to follow this month, the 8th of June, the 16th of June, and the 24th of June. Emma Gerard is our region chair in Wales and will introduce our first Vets Cymru 2021 speaker. Thank you, Emma.
Thank you, Kate. Welcome, everyone. So I'm really delighted to have Sue Paterson with us this evening, and in my opinion, she needs no introductions. So she'll be doing the session this evening on dermatology with a Welsh twist, which we're really excited about. So with the Kahoot quiz, we are going to do a bit of a competition. So the person with the highest number of points will get the opportunity to win a BSAVA manual of their choice. So we'll keep an eye on that, and if we'll pop a message in the chat box for you to get in contact with us later on in the session. So without further ado, I will pass you over to Sue. Thank you very much.
Thank you, Emma, and we should say congratulations to you, Emma, for taking over the chair of the Welsh region. Our first, I think I'm right in saying, our first nurse to chair a region. So many, many congratulations. I know the region's in really safe hands, particularly when you've got people like Kate in the wings there to help drive things forward. So the Welsh region is such a strong region. You guys are doing a great job. And it's such a shame that we can't be with you all in person, but we got the next best thing, which is a quiz. So I'm going to come clean right at the beginning and tell you that we are all pretty much Kahoot virgins here. So this is the blind leading the blind, and hopefully this is all going to work when I press the first button and we get going. We're going to do a few questions on parasites in dogs, a few questions on parasites in cats, and just to make it nice and even, we're going to do a few questions on parasites in horses. And then in between those 3 veterinary rounds, if you will, I'm going to throw in some Welsh questions. So there should be a distinct advantage for those of you who are Welsh, but hopefully everybody can have a bit of a bash at these, even if you don't know your Welsh facts and figures, and recognise your Welsh landmarks as well. So let's get going and see if this actually works. So here is our first question. What is the most likely cause of this Westies skin lesion? And you begin 30 seconds for each of these, and this is all about fastest finger first. You've got 4 particular options here. The first of those is atopic dermatitis. The second one is dermatophytosis. The third one is flea allergic dermatitis. And then the last one is anal sacculitis. So which of those 4 options do you think is the most likely cause of the distribution of signs that you can see on this West Highland White Terrier? Okay, so interestingly, we had a few say atopic dermatitis. We had 1 person say dermatophytosis, and the majority just said flea allergic dermatitis. And what I would say to you is, when you're looking at distribution of clinical signs, atopic dermatitis, of course, affects flexural surfaces, affects the ears, affects the face, affects the feet. but when you've got involvement of the dorsum, always think flea allergy first. So for me, anything that affects the dorsal area, whatever the breed, always think about fleas, and make sure you rule out fleas before you start to look at everything else. So well done to those of you who put flea allergic dermatitis. Let's see what that does with our score. And obviously all of these people got the right answer, including Chicken. Welcome, Chicken. It's very much about who gets the right answer first at the end of the day. Okay, so that's our first question. Now we know how we're doing. Let's go on to our second one and see how we go with this. So we're going to give you the names of 4 flea adulticides, and I want to know which of these 4 has got the fastest speed of kill. And I've given you imidacloprid, I've given you saralena, I've given you fipronil, and I've given you selamectin. So you've got 4 actives there, which of course we'll find in veterinary products. Which of those do you think has got the fastest speed of kill when it comes to the treatment of fleas? And we're specifically, remember in this section, talking about dogs. Okay, let's have a look. Okay, and again, it's very split. And what, of course, we have to remember when we're looking at flea products is that all the flea products that we're going to have that are POMVs that we've got available to us as veterinary surgeons are all going to have really good efficacy against fleas. And most of the over-the-counter ones as well will also have good efficacy against fleas. And something like fipronil, for example, will kill fleas effectively and will stop fleas feeding because it will kill them within 24 hours. But for me as a dermatologist, when I'm looking to treat a flea allergy, I want it to work really, really quickly. And so saralena is the drug that I would tend to use. And I put saralena there, to be honest with you, it's interchangeable with all the other isoxazolines. So whether you're using saralena, whether you're using floralena, whether you're using afoxalena, whether you're using lotilena, so that's Bravecto or Nexgard or Simparica, they're all really good and they will kill fleas within about 6 to 8 hours. So it's a really superior speed of kill to everything else. So for me, that's why they're really good. One of the hot things, of course, at the moment is environmental impact of ectoparasiticides, and we're really not sure. The jury's out for fipronil and imidacloprid, but we're not sure whether isoxazolines may have a similar effect. So let's see what that's done to our leaderboard. Jumble things up a little bit. Well done, Jasmine. Obviously very quick off the mark. Let's look at our third question then on our canine section. So this is a little bit more difficult. What do we mean by intrinsic canine atopic dermatitis? And I've given you 4 options here. Obviously, you're reading these through. So one is where there's no demonstrable allergen-specific antibodies, where the disease is triggered by internal allergens, so things like house dust mites, where the disease shows strong hereditability, or where there are known to be classic changes in the skin microbiome and the skin barrier. So giving you 4 different options there. Which of those do you think you've actually got? Okay, so the right answer is the first one. Well done to those of you who got that. And let's just talk very briefly about what we mean by intrinsic canine atopic dermatitis. This is based on the same situation in people. We know you can see either extrinsic or intrinsic canine atopic dermatitis as you can in man. And the intrinsic form is where the dog does not produce allergen-specific antibodies. It's not the same disease we suspect as the classical atopic dermatitis. And these are the dogs that when you do an allergy test, you're absolutely sure they've got atopic dermatitis because you've done your food trial, you've ruled out parasites, you've ruled out infection, but the blood comes back from the lab and there is nothing on it at all. There are no positive reactions. Those are the dogs who have intrinsic atopic dermatitis. We think it's T helper 1 mediated rather than T helper 2. So the possibility is that these dogs won't respond to things like oclocitinib or lokibetamide either, because they're looking at interleukin 31, which is a T helper 2 cytokine. So you'll see some of these. We're not sure how many. Possibly 20 to 30% of dogs can have intrinsic canine atopic dermatitis. So let's see what that's done to our leaderboard. Well done, Jasmine. Possibly a little covert dermatologist there in the background. Let's see what we got with our next question. So this is the 5th of these for our canine section. Which of these drugs has got the highest rate of efficacy for canine atopic dermatitis? So which of these do you think has got the highest success rate? We're looking at steroids, oclocitinib, allergen-specific immunotherapy, so skin vaccines to you and me, or do you think they're all pretty similar? Which do you actually think is the most is the most successful of those, or is there nothing to choose between them? Let's see what we've all got on that one. Okay, so we've got prednisolone, they're out front, and just a few people are saying they're all similar. Well, if you look at what is actually in the evidence, the scientific evidence base, they are all pretty similar. Prednisolone, allergen-specific immunotherapy, and ocrelizumab all have got success rates in clinical papers of about 65 to 70%. What, of course, is different is the speed of onset. In ocrelizumab and prednisolone will work really quickly to control pruritic and control clinical signs, but allergen-specific immunotherapy, although it's a bit of a slow burner, will produce the same level of control, so it's always worth considering. Okay, so let's see what that's done to our leaderboard. Chicken still up there with Sue and Jasmine, but Francis sneaking up on the outside. Okay, so now, the final question in our canine section before we go into our Welsh questions. So this is an atopic dog, and this is the interdigital space on this dog in close-up. It's not responded to ocrelizumab. What do you think's going on in this case? Do you think there's malassezia there? Do you think there's staphylococcal there? Do you think there may be demodex there? Or do you think this is one of these cases where we've got ocrelizumab resistance? Which of those do we think? Okay, so most of you said malassezia infection. Absolutely right. And of course, that's just to remind you that when you get something where you put completely rational therapy in place like ocrelizumab and it hasn't responded to treatment, go back, reassess it. Check for infection, bacteria, check for infection, malassezia, and of course, check for parasites. You can get parasites in that interdigital space, but in this case, the clinical appearance there, that horrible brown, greasy discharge, is much more consistent with malassezia. So let's see what that's done. Okay, so Sue's sneaking up on the outside there. Well done, Sue. And Hannah is the highest climber. Okay, so I think our next questions are going to have a Welsh bias to them. So let's see how you're going to do on some Welsh questions. So here we go, I think, with the first one. Nice, easy one to start off with. When is St. David's Day? And I'm expecting 100% on this, please, ladies and gentlemen. March the 1st, March the 17th, April the 23rd, and November the 30th. They are all actually Saints' Days, but which of those Saints' Days is actually St. David's Day? St. David, of course, being the patron saint of Wales. Let's see. Let's see how we're doing. We count down. Okay. So 12 said March the 1st. And obviously, I'm going to say the non-Welsh components of our quiz, obviously, are the ones that got it wrong. There won't be a single Welsh person, I'm sure, who's got St. David's Day wrong. March the 1st, of course, is St. David's Day. 17th, of course, is St. Patrick's Day. April the 23rd, St. George's Day. And November the 30th is St. Andrew's Day, the patron saint of Scotland. So let's see what that's done. Shaking it up a little bit, but Chicken and Sue are still there at the top. Okay, so let's look at another Welsh question now and see what we've got here. How many national parks are there in Wales? And I've given you, obviously, 4 options here. Are there 2? Are there 3? Are there 4? Or are there 5? How many national parks are there in Wales? Let's see as we count down there. We've got 17 answers, probably another couple of people to make their decision unless they're rapidly Googling it to find out what the answer is. Okay, let's have a look. So the correct answer is 3, and they are Snowdonia, Brecon Beacons, and Pembrokeshire. I only know because I've got that written down. So well done to those of you who got that one right. Let's see if that's made any difference to the people that, oh, Jasmine's catapulted up to the top there, but Chicken's still holding its own. So let's have a look at another of our Welsh questions and see what we've got here. Okay, so some of you may or may not be aware of the Welsh coastal path. So how long is the Wales coastal path? And I've given you 4 options here. Is it 297? Is it 450? Is it 675? Or is it an enormous 870 miles long? How long is the Welsh coastal path? Let's see how many of you managed to get this one right. And well done to those of you who said 870 miles. That is it. Yes, the Wales coastal path is 870 miles long. Okay, what's that done to our, oh, shaking it up a little bit. So Sue's gone up to the top, but Jasmine's got a streak with 3 correct answers in a row. Well done, Jasmine. Okay, so let's have a look at our next question, which again is another Welsh one. And this one, who is the most capped Welsh rugby player? And I've given you 4 options there. So Gethin Jenkins, George North, Alan Wynne-Jones, or Stephen Jones. Who is the most capped Welsh rugby player? 4 options there. Let's see how many of you know your Welsh facts. We count down to 0. Let's have a look how many people have got it right. Okay, wow, that is seriously impressive. Yeah, absolutely. Alan Wynne-Jones has got 148 caps, Gethin Jenkins 129, Stephen Jones 104, and George North 102, although I suspect he may get a few more yet. Well done. That is seriously impressive quizzing. You obviously know your Welsh rugby players. Let's see if that's made a difference. I think that was all about fastest finger for that one. Okay, so let's have a look at our next one. And this, I think, is the final one in this section on Wales. So what is the second highest mountain in Wales? And I'm not sure whether I should even attempt to pronounce these for you, but I've given you 4 mountains there that are amongst the highest in Wales. Which of those is the second highest? Obviously, Snowdon is the highest of those. Which of those is the second highest mountain? See how many of you know your mountains. Okay, let's have a look. Oh, split a little bit. So yes, the answer there is Carnad Llewellyn, and that is 1,064 meters high. The next highest is Glydderfawr. My pronunciation is not good. Apologies to everybody. And then Egan, and then Elidir 4. So 4 very high mountains, but the highest of those is Carnad Llewellyn. Okay, so those I think are our Welsh questions over. Let's see if that's made a little bit of a difference. So Gio's doing exceptionally well, a streak of 5 correct answers in a row. Well done, Gio. Let's go on now to our next lot of allergy questions. And these are looking at horses now. So this is our horse section. And what I've got here for you is a parasite. This is a parasite probably taken from a skin scraping from a horse's leg. What is this parasite? So I've given you Coreoptes bovis, Sarcoptes equi, Damolinia equi, or Dermatitis gallinae. Which of those is the answer to that one? And what we've got on this one is that actually Coreoptes bovis. So those of you who put Sarcoptes equi, I don't know whether I can go back a thing or not. Let me see if I can go back a page. No, I can't, so we won't bother. So Coreoptes bovis, it's an oval-bodied mite that we see, of course, in horses. Sarcoptes equi is not a parasite that I'm aware of. Sarcoptes equi is a made-up name. I'm really sorry about that. And Sarcoptes is very different. On skin scraping, is a much rounder mite rather than that very oval mite that we see, that sauroptiform type of mite, which is very typical of Coreoptes bovis, which causes leg mange, of course, in the horse. Okay, so let's see what that's done. Stirred it up a little bit, chicken moving back up again there, but Sue and Jasmine still at the top. Okay, so we should have now another horse question. So which of these will not cause urticaria in the horse? And I have given you 4 answers there. Molds and pollens, topical and systemic drugs, exercise and heat, or watching rugby. Which of those will not cause urticaria in the horse? I've given you 4 different options. Okay, those are counting down really quickly now, aren't they? So I'm pleased to say you got that right. And this was a difficult one, actually, because pretty much anything can cause urticaria in the horse. So we get immunological reactions, which are inhaled allergens, so things like molds and pollens. Molds can particularly cause urticaria in the autumn. We see it in horses in the autumn time, often after they're stabled as we start to get some cold weather. Of course, pollens during the summer. Drugs can, whether they're drugs that are applied to the skin, whether they're drugs that are administered. That can be wormers, that can be vaccines, that can be antibiotics. And we also recognize what we call physical urticarias. And these are things triggered by exercise, by heat, and by cold. So pretty much anything except watching rugby can actually trigger urticaria in the horse. And that's why it's such a difficult disease to investigate, because so many of these cases are idiopathic. They respond to symptomatic treatment and then get better all by themselves. So let's see what difference that's made. Okay, so still Sue and Jasmine there, but Rab's just hit an answer streak of 3. Well done, Rab. Okay, so let's have a look at our next equine question. And I'm going to show you some lesions on a horse now, over its rump and over its tail base. What is the most common reason that you would see these types of lesions on a horse? Remember, these aren't necessarily going to be difficult. Sometimes these are really obvious answers. So I've given you different options there. And the right answer on that one is sweet itch, quite obviously. Tail base and, of course, mane, we'd expect to see the sweet itch. All of those other diseases, though, can cause irritation in that area. Atopic dermatitis can mimic sweet itch exactly in the horse, and you can see involvement of the mane and the tail. But usually in atopic dermatitis, there's also involvement of the flanks. Oxyuris equi, of course, you'll cause problems around the perianal area. Doesn't normally extend on the rump, as you saw in that case. And the other thing which you may not have come across is intertriginous malassezia. You can get horses that sweat up in those skin folds around the anus underneath the tail. It can get colonized with malassezia, and that can cause quite marked pruritic. I've certainly seen cases of that. So something that you need to be aware of when you're looking at these sorts of cases. Okay, let's see if that's made any difference to our scale. Okay, so Jasmine and Francis here sneaking up the lead. Well done on Rab there's on a winning streak of 4 correct answers. Okay, so let's have a look at another one for horses. And I've given you a picture here of a horse which has lesions on its flanks. So what are these lesions likely to be? And I've given you 4 options: staphylococcal folliculitis, eosinophilic granulomas, fungal granulomas, or generalized mastocytosis. What do you think the most likely reason is for these types of lesions on the flanks of this horse that you can see here? Okay, well done to those of you who put eosinophilic granulomas. That's absolutely right. Staphylococcal folliculitis can look not dissimilar to that, but it's almost a sort of moth-eaten type of appearance, and you get little raised areas of the hairs that are clumped together with crust. Whereas these eosinophilic granulomas are much more solid lesions. And if you pick them up, you can feel them really quite solid. Some of them can actually become calcified in the center. So if you put a fine needle into them, it's actually slightly gritty in the middle. You need to be careful. I have seen horses with fungal granulomas caused by saprophytes on the flanks. So you should be sure that you're dealing with an eosinophilic granuloma before you start to put treatments in place. But they are almost always a manifestation of an allergy, and usually they respond beautifully to prednisolone therapy. So let's see what we've got here. So Jasmine's still there at the top. Well done, Jasmine. We've got Hannah now sneaking up on the outside. Okay, so let's look at our next question. And this one's about atopic dermatitis in a horse. And I'm going to give you 4 different options here. Which of these is not suitable to start a horse on to treat atopic dermatitis? So I've given you 4 treatment options there: cetirizine, sublingual allergen-specific immunotherapy, amitriptyline, or prednisolone. And I've given you the dose rates for 3 of those drugs as well. So which of these is not suitable to start a horse on to treat atopic dermatitis? Let's see what we've got on this one here. Okay, so apologies for being slightly underhanded on this one. Cetirizine is a perfectly good drug to treat atopic dermatitis, but not at that dose rate. I would normally use it at 1 milligram per kilogram, not 10 milligrams per kilogram body weight. Sublingual allergen-specific immunotherapy is really good in horses. It's a really useful way to treat them. Most owners can handle their horses really well. Drops that just go onto the tongue, because horses are used to having their mouths handled. It's a really useful form of therapy. Amitriptyline is also quite good too, and particularly with some horses that get very agitated. Amitriptyline does have some antihistamine activity and can be something that can sometimes dig you out of a hole. You've got a horse that hasn't responded to antihistamines and you cannot give it prednisolone. So something to be aware of. And of course, steroids at 1 mg per kg is an exceptionally good drug to treat atopic dermatitis in the horse. Obviously, you start it on those and you then taper it down to the lowest possible alternate day regime. So I wouldn't want a horse to stay on steroids at that dose rate because of the associated risk of that, but it's a good drug to start them on. Okay, let's see where we've got with this one here. All right. Don't see that that's actually done an awful lot to the scores. So let's go on to our next one. Okay, so this is our next lot of Welsh questions for you. I'm going to show you some landmarks now, and I want you to identify where all these landmarks are. So where is this? And I've given you 4 different castles. Obviously, we're looking at a castle here. Which is these castles? Is it Carnarvon? Is it Conway? Is it Beaumaris? Or is it Aberystwyth Castle? Which of those 4 castles are we looking at this particular, on this particular picture here? What do we think we've got going on here? Okay, so let's have a see what we've got. Absolutely, that is Conway Castle. Well done to those of you who got that one right, very definitely. Okay, let's see what that's done to our scores. And obviously Jasmine and Sue know their castles as well as everybody else. Let's go to our next landmark. And so again, hopefully this should be fairly straightforward for you. This is all about speed. Which skyline is this? Is that the skyline of Aberystwyth? Is that the skyline of Swansea? Is that the skyline of Cardiff? Or is that the skyline of Portmaddock? Which of those 4 skylines are we looking at there on this particular picture? And as I say, this shouldn't be a difficult one, I would hope. It should be very much a matter of who can get their answer in the most speedily when it comes to this. Okay, let's see what we've got. Absolutely. So it's Cardiff. Well done to those of you who got Cardiff as the right answer on that one. Let's see if that's done anything. And obviously Jasmine knows all her Welsh landmarks. Well done, Sue and Gio, but Chicken there sneaking back up again, which is nice to see. Okay, so let's have a look at our next one. And again, this is another Welsh one, and this is another landmark for you to look at. Where is this? And again, I've given you 4 castles to look at. Is this Cricket Castle? Is this, I can't pronounce that. Is that Lowharn Castle? Is that Pembroke Castle? Or is that Aberystwyth Castle? Which of the 4 castles that I've listed for you there are you looking at here? It's fairly unique in its position and its outlook there out across the bay. So hopefully that should be fairly straightforward for you, and I'm expecting high marks. Okay, it's actually Cricket Castle. So well done to the 3 of you who got that one right. Let's see what effect that's had on our score. Oh, well done, Jasmine, doing really well, but RVN1 is sneaking right up the leaderboard there. Okay, so next one for you, our next Welsh question here. Where is this pier? And hopefully, again, this should be pretty straightforward. I've given you 4 options though. Is that Tenby? Is that Llandudno? Is that Colwyn Bay? Or is that Ross-on-Sea? Which of those 4 piers are we looking at here on this particular picture? Tenby, Llandudno, Colwyn Bay, or Ross-on-Sea? Let's see how we're all doing with this one. Okay, well done for those of you who got that one right. I think that was a fairly easy one. That was Llandudno Pier. So let's have a look at what that's done to our leaderboard, if that's made any difference. A little bit of a shake-up at the top, and let's go on to our next question. Okay, so another one for you, another landmark in Wales. Where is this? And again, I've given you 4 different options. Hopefully this should be really easy. Is that Beaumaris? Is that Pembroke? Is that Chepstow? Or is that Carnarvon Castle? Which of those 4 castles are we looking at here? It's a rather gorgeous photograph. Probably the sky's about the same colour now, I should think, at that particular castle as it is there. Okay, let's see how we've done with that one. Absolutely right. Well done to those of you who put Carnarvon. That's Carnarvon Castle that you can see on that particular picture. Okay, so, oh, a little bit of a shake up there at the top of the leaderboard. So well done to those of you who know your Welsh landmarks. Okay, so I think we are now looking at some feline allergy questions in our last section. So which of these is not a reaction pattern seen in feline atopic syndrome? And there's actually a typo on this one. That should say feline atopic skin syndrome to be completely accurate. And I've given you 4 different things here. One of them is miliary dermatitis. One of them is plasma cell pododermatitis. One of those is head, neck and face pruritus. And the other one is self-induced alopecia. So which of those reaction patterns is not seen in feline atopic dermatitis? And well done to those of you who put plasma cell pododermatitis. And I put that question in really just to give me an excuse to talk to a tiny little bit about the new consensus status that's come out about feline allergy. It's an open access paper. If any of you are interested, it's been published in Veterinary Dermatology. It's a series of 4 papers published in February this year in Veterinary Dermatology Journal, and it recategorizes the feline allergies that we recognize. And it categorizes them with a big umbrella title, if you will, of feline atopic syndrome. And then underneath that, it then puts that into 3 separate groups, either cutaneous, gastrointestinal, or respiratory different groups. So we now recategorize those, and it means that feline asthma is now been categorized as a form of atopic syndrome in the cat. So let's have a look at our leaderboard, if that's made any difference there. A little bit of a shake up at the top. And let's have a look at some more feline allergy questions and talk a little bit more about these new categorizations that we know now exist for feline allergy. So which of these is not a potential differential diagnosis for this feline rodent, or sometimes called eosinophilic ulcer? When you're looking at this type of ulcer in a cat, it may well be in the majority of cases that it is a rodent ulcer, but there are other things that can look like it. So which of these is unlikely to be on your list of differential diagnoses when we're looking at a feline rodent ulcer? And calicivirus should be there. Cryptococcus should be there. You certainly can see these ulcerated lesions around the face on a cat. You can see autoimmune skin disease in the cat. I could show you a picture of bullous pemphigoid that looks very similar to that. But rarely are you going to see Demodex at mucocutaneous junctions causing ulceration like that. So when we're looking at differential diagnosis for a feline rodent ulcer, before you reach for your steroids, you should be considering whether it may be something else, because quite obviously, although steroids will help bullous pemphigoid, they're going to make a calicivirus infection or cryptococcus infection considerably worse. So just for you to be aware that there are other things that can look very similar to a feline rodent ulcer. Let's have a look if that's made any difference. A little bit of a shake up there at the top. So let's see our next feline question and see what we've got there. Okay, so which of these is the most common presentation of food allergy? And I have given you 4 different things here. I've given you miliary dermatitis, I've given you head, neck, and facial pruritus, I've given you eosinophilic granuloma complex, and I've given you self-induced alopecia. Which of those is the most common presentation of feline food allergy? And this is based on these new consensus papers that have been published, as I say, in the last couple of months. Let's have a see what we've got. And absolutely, head, neck, and face pruritus is what I was taught when I was doing my dermatology qualifications, and what is in the literature as being the most common presentation for food allergy. But the consensus paper actually looks at a whole range of different studies, and looks at a total of over 153 cats with food allergy, and breaks those down into one of these 4 presentations: so miliary dermatitis, head and neck, eosinophilic granuloma, or self-induced alopecia. And of those 153 cats, 52 of them presented with self-induced alopecia. The head and face, head and neck pruritus was seen in 42, miliary dermatitis in 31, and eosinophilic granuloma context in just 18. So if you've got a cat with self-induced alopecia, feline food allergy should be really high on your list of differential diagnosis. Of course, it should also be on a differential diagnosis when we're looking at facial lesions too, but it's certainly a change in the literature on the basis of this big consensus status, which looked at all the publications around feline food allergy that are there in the literature. So let's have a look if that's made any difference to our leaderboard. Don't think that's actually doing very much, so let's leave that and go on to our next question. Okay, so hopefully this is a nice straightforward easy one. What is the predominant cell on this impression smear from a lesion of miliary dermatitis? So hopefully you can see that in the middle of your screen there. I've given you 4 different options: mast cells, neutrophils, eosinophils, or basophils. So those large cells with bilobe nuclei, dark red staining granules you can see there in the cytoplasm. Hopefully that should be a nice straightforward diagnosis when we're looking at that. Okay, so well done to those of you who put eosinophils. Those were eosinophils. So eosinophils are the cells, when we see these in a cat, that are very typical of allergy. When we see eosinophils in a dog, it's far more consistent with a parasite. And so impression smears from lesions of things like rodent ulcers, things like miliary dermatitis, things like eosinophilic granuloma complexes, generally, it's really nice to see large numbers of eosinophils there because it can help confirm your diagnosis. So when we were looking at that cat with a rodent ulcer, an impression smear from that is really useful. When you're looking at a cat with miliary dermatitis, again, an impression smear is really useful to look at those cell types, and that helps you rule out other potential differential diagnoses. The other thing that's also really useful as well with an impression smear is you can get a feel for how much infection there is there, because although pyoderma is really rare in the cat, you will find a lot of these eosinophilic granulomas are actually infected with staph. And if you give these animals either topical therapy with something like chlorhexidine mousse, for example, or you give them systemic antibiotics, you will see dramatic improvement with antibiotic therapy alone. So cytology is really important, looking for eosinophils to be sure that you know what you're dealing with. And it's also really important to see if there's any evidence of infection there, because that can help guide you when it comes to looking at your treatment options. Okay, so let's have a look at what that's done with our scores. A little bit of a difference there at the top, but not an awful lot. So Jasmine there at the top still with, I think we just got one more question to go. So let's look at our final question now. Which of these cannot be used to treat a cat with allergy? And so I've given you 4 options here. Hopefully this one should be fairly straightforward again. Allergen-specific immunotherapy, dexamethasone, ochlorcitinib, or lokivetmab. Which of these cannot be used to treat a cat who has got an allergy? Which of those do you think you should not really be reaching for when we're looking at therapy of an allergic cat? And of course, there are other drugs that I haven't mentioned there. I haven't mentioned, for example, something like for example, cyclosporin. So well done to those of you who put lokivetmab. Allergen-specific immunotherapy, really good in cats. There's not a lot in the literature, but certainly the papers that are about suggest it's a useful form of treatment. And it's amazing how many owners can actually inject their own cat. The beauty of things like the subcutaneous injections is they only need to be given every 4 weeks, so it is a useful form of treatment. Dexamethasone is really good. I like Dex. I think it's better than Pred in cats, and so it's a really useful form of therapy. Normally, I'd use it at between 0.1 and 0.2 milligrams per kilogram once daily, and I usually use that for sort of 10 to 14 days to get the animal into remission, and then I cut it down to perhaps twice a week after that for maintenance therapy. Dexamethasone, because it's a relatively longer acting steroid, you need to use it slightly less frequently. Ochlorcitinib, it is a licensed drug for the dog, but we're starting to see some reports coming through of its use in the cat. It seems that the cat metabolizes this slightly differently, and when it's used in the cat, it needs to be used at double the dose rate, at least double the dose rate of the dose rate that we see in the dog. So in a dog, we'd use it at 0.4 to 0.6 milligrams per kilogram body weight. In the cat, you're looking at 1 milligram per kilogram body weight, probably as a starting dose. It isn't licensed. We are not aware of any long-term studies. We know in some of the studies that have been taken place that it does cause problems with renal parameters, but it is a drug that we are starting to see used more and more in cats. And I suspect at some stage in the future, it may even be licensed for use in the cat. So it does seem to have some benefits. However, lokivetmab is the one we shouldn't be using because it's a canonized monoclonal antibody. And so if you use lokivetmab in a cat, even though it's very specific, even though it's very safe in a dog, you're very likely to create a very severe allergic reaction in the cat. It might tolerate it the first time, but the second time it's very likely to produce a reaction. And the problem, of course, we got with the cat is we don't know how important interleukin-31 is, and therefore we don't know whether it would work at all. But that's a drug you should very definitely avoid when you're looking at an allergy in the cat. Other things we've not mentioned, antihistamines. I'm not a great fan of antihistamines in cats. and cyclosporin, underused drug nowadays, but it's still useful, used with appropriate safeguards in place, like blood sampling for leukemia and FIV. Again, it's a useful form of treatment in a cat. Okay, so that's our last slide on feline allergy. Let's see what that did to our score. So 14 out of 25, we've got Sue. Well done, Sue. Again, a 14 out of 25, but in top place with 15 out of 25, we have Jasmine as our winner. So well done, Jasmine. And then RVN1 and Geo in 4th and 5th place. So well done, Jasmine. Well done to getting 15 out of 25. I'm sure if you make yourself known to the organisers, you'll be able to get hold of your BSAVA manual of your choice. So hopefully that was a little bit of a light entertainment. Thank you for joining us this evening. We look forward to seeing you all next year face to face, and I look forward to savouring some of your fantastic Welsh hospitality again. The first Vets Cymru was amazing. Many congratulations to all the people who organised it. I'm really looking forward to coming along again and participating next year. So thank you for inviting me to this. I hope you enjoy the rest of the sessions. I'm going to hand you over to Emma and Kate again.
Thank you, Sue. That was brilliant. Yeah, I really loved that, and I'm sure everyone else did as well. So I think we need to thank ECMIA again for sponsoring this evening and for everyone for joining us. Yeah, we're absolutely looking forward to getting back to face next year as soon as we can. Kate, have you got anything else you'd like to add?
Oh, big thank you to Sue. That was just absolutely brilliant. I clearly don't know my Welsh geography at all, and little did I know I was going to get tested on geography tonight. So that was a nice little sort of side swipe there from veterinary medicine. Made a nice change.
But you knew your Welsh rugby players, though. That was impressive. That was impressive quizzing with the Welsh rugby players. That was very good.
Yeah, there was some great answers actually, and some great responses. Thank you very much for everybody for taking part, and you know, for showing yourselves to be such good sports. And especially congratulations to Jasmine. Jasmine, if you make yourself known to Jenny Bartholomew at BSAVA, if you drop a line to anywhere at BSAVA and ask for it to get through to Jenny, we'll get a voucher out to you for a manual of your choice. You've well deserved that, to be fair. Do join us, everyone, on our other webinars in this series. If you keep an eye on the dates, they're all on the Vets Cymru website at BSAVA. And we look forward to seeing you there, and also very much so in June 2022. We've tried twice now, and COVID has beaten us each time to rerun the Vets Cymru that we had in 2019. It was really excellent, such good fun, and I know a lot of people have been asking us when's the next one going to be. So 2022, 18th to 19th of June. Thank you very much, everybody, and thank you again to Sue and to Emma for this evening.
Pleasure. Stay safe, everyone.